Have you ever had pain that wouldn't just go away? No matter how many stretches you did or how many doctors you saw, it just wouldn't go. You're not alone. Chronic pain affects over 50 million Americans, and for many, the spine is at the center of it all. I'm Dr. Jay Rutland, and today on the Health Exchange, we're joined by Dr. Rick Paicius, a pioneer in integrated pain management. He's also active in research, primarily in the fields of neuromodulation and regenerative medicine. We're going to unpack the mysteries of spine health and explore real solutions for pain. If you've been told just live with it, this episode is for you. Dr. Paicius, how are you?
Great. Good seeing you.
It's great seeing you again. It's funny because we met a few years ago, right?
2-3 years. Yeah. You look good.
So do you.
What's your secret, man?
Oh, please. I mean,
You got some vitamins, you got some peptides going on. What's happening?
I think it's genetics and exercise.
Yeah.
That's it.
Yeah.
No, I mean, when we met originally, it was right when I was coming out to kind of do my own thing.
Right.
And I was exploring where I was going to do procedures, and you have a procedural suite. I remember one of the questions I asked you at lunch was, what got you into the field that you're in today?
Yeah. Interesting, right? Because who wants to deal with whiny pain patients all day?
Yeah.
I started in anesthesia. So I started working anesthesiology at a trauma center in Orange County. It was fun. It was fast paced. It was just like the movies or the television scene. Somebody comes in, surgeon's got his hand on their heart doing open heart massage. You've got to get them dialed in so they survive. And that was cool for a couple of years.
Yeah.
And then after a couple of years, and you're on call every second or third day, you're like, maybe it's not as cool as I thought it was. So at that time, this is like over 25 years ago, it was right at the beginning of pain management. So in anesthesia, we would do simple pain management procedures, blind epidural steroid injections, some nerve blocks, so forth. We were always injecting the spine with a spinal anesthetic, whatever. So we were comfortable with that.
Yeah.
But then the advent of using live fluoroscopy, live x-ray, different techniques that we typically got from Europe, a lot from the Netherlands, and those were just being introduced in the United States. And I always had a penchant for this. So as this started to develop, I dove into it more and more, took more courses, spent time at different places to learn the newest and greatest techniques. And after a bit, with people recognizing that pain management is essential, it's needed because most people don't want to deal with it.
Yeah.
And having a bigger toolbox to work with made the transition from anesthesia to pain management. And it has been a really rewarding career. It helped a lot of people. Not everyone, because you can do what you can do, but there are limitations. The satisfaction you get from actually interacting with these people who are often hopeless and getting a good chunk of their life back. Yeah, I always feel like I'm a blessed missionary.
That's, it's a fascinating story because I can hear when you're telling the story, I can hear the passion behind it. And I can hear, I really, really want to help these people. Like I really, really want to do something about this. One of the things we're talking about is because of the development of medicines over the course of time, the medicines we developed 100 years ago have a lot more side effects than the medicines that we're developing now.
Absolutely.
One of the issues we have, at least with pain, is using opioids, right? And so we know that opioids are effective, and generally they're going to drop a bomb on your brain, tell your brain you're not having pain, but they also tell your brain not to breathe, right? They also give you a euphoria, a feeling of, pleasure, which I'm not saying don't have pleasure, but I'm just saying that's what leads to addiction.
Right.
And so it's a real crisis right now with opioids and opioid addiction. And I think that some of the things that you're doing is alternatives to just giving opioid.
So I'm not pro-opioid and I'm not negative opioid. Right. I'm pro-patient. So good example. I had this 80-year-old lady. She's got multiple arthritises, just pain. I put her on a low dose of time-release morphine twice a day. Doesn't goof her up, doesn't make her sedated, allows her to function. I can inject her from here to forever at every little spot, which may or may not be beneficial. But in a case like that, that's reasonable. So what happened is, if we look at the pyramid of docs, we've got docs who understand what's going on and do the right thing. It's the majority. Then you've got a smaller amount who are motivated to do the right thing, just don't know what they're doing. And that's where the overprescriptions typically occur. when you've got that small subset who's going to meet you at Starbucks and give you a script for $300, and they usually wind up in jail, which is great. When we look at opioids in the 60s, 70s, they were reserved for, bad things, big surgery or something, anesthesia, whatever, something like that. And we just didn't really prescribe them that much. And then the Sackler family, who came up with MS-Contin and then subsequently OxyContin, realized that they could sell this painkiller that they said was not addicting, that was not problematic, and if you need more, you can have more. They paid physicians to publish articles that were not real, that were inappropriate. They had a sales force that was second to none, that went to every doctor who wrote any kind of opioid and promoted. And they would do a lot of things that are illegal today, buying this or that, or, not a car or something, but maybe a trip or a weekend away and so forth like that. And they kept pounding the notion that these are not a problem. They need more, use more. It's the fifth vital sign. You're paying.
That's the Keaton movie, isn't it? Isn't that?
Yeah, amongst others. Yeah. The Sacklers were unbelievably bad people. And so they created this market force. Well, as times went by, we're like, this was wrong. And it took time for everyone to catch up and go, this is baloney. And so then it became draconian. The state, California, was saying, you can't prescribe more than this. Well, I've got a patient who's, metabolizes differently than other people. And they have a serious thing, and it's the only thing that helps. So you've always felt like you're like living in the red zone, and the brown shirts are going to come and get you anytime. So it's been changed. Guys like Sean Matthews had a pain at Stanford, great guy, really smart guy. He was on the medical board to help now say, hey, if it's appropriate, it's appropriate, which is better. But again, in the right usage, they're great. What's interesting, a new drug just came out. And what it works on is it works on a certain sodium channel. There are people, everything you think is a TV show right now, where there's some guy who can't feel pain. He steps on a nail. It's a genetic mutant of a gene that expresses the NAV17G, whatever that means. I know what it means, but, for listeners.
Yeah.
So this particular sodium channel is what propels the nerve fibers to send pain.
Yes.
Okay? So they found an oral version. They developed an oral version which inhibits this. It's not an opioid, doesn't cause respiratory depression. There's no euphoria. There's nothing wrong with it. And so
It inhibits the sodium channel so you don't get the action potential on that particular nerve fiber.
correct. Journovix is the name.
Yeah.
That's the trade name. Interestingly, for this big pain meeting organization, American Society of Pain Neuroscience, I was a head of translational research. So I would bring in different people. There's a group out of San Diego. What they're doing is they're taking CRISPR technology and they're injecting it into the nerve root. So say someone's got chronic sciatic pain. So there's a little part of our nerve right as it exits the spine called the dorsal root ganglion. They're injecting the CRISPR technology, which is going to affect the genetics, to create that deficit in the NAV17G. Interesting. So this target's been around for a long time. It's just like CGRP has been, for headaches, has been known for a long time, but just only in a few years have developed molecules that aren't toxic. So the approach with opioids is they're a useful tool, used right.
Yeah.
I mean, that's the short answer. Most of the opioid deaths today that you see, overdoses or fentanyl, 90% of them, at least 90% of them. So the opioid crisis is a different opioid crisis than we had 20 years ago. 20 years ago, we had this escalation of OxyContin and other drugs that caused people to become addicted. And when they put a kibosh on that, what they turn to? Heroin. But then what happened to heroin? Well, now it's laced with fentanyl. Not too good. You may get the wrong dose. And xylazine. So, I mean, there's so many. They created a monster, which we now have a secondary monster from.
One of the things that you guys can do is nowadays, now that we understand a lot of these molecules and products, there is an antagonist for opioids. called naloxone or Narcan
Mm-hmm.
that you can actually get delivered through your nose, right? It's just an intranasal
Mhm.
injection that you can use now. Now you can get that over the counter at certain places. You can also get it for free at certain places. So listen, if you have a friend or you suspect that somebody is overdosing on opioids, they're sleeping,
Abusing opioids.
abusing
The
opioids.
potential for overdose.
Yeah.
Yeah, they're very common. We just routinely give naloxone to our patients. We prescribe it to them and make sure it's up to date and so forth. Anyone who gets any opioid, because it's not so much that, I get a 75-year-old lady who needs 3 Norco a day just to get by and it's fine and it works and she doesn't need it. That's fine. No side effects. Well, she's got that thing in her cabinet.
Yeah.
But if her grandson comes over and decides, oh, cool, and he overdoses, you've got the Narcan. So that's one scenario, not only for the person who's prescribed the medications, but for the secondary effects that may occur.
Yeah. So look for it. And if you're taking an opioid and you have particularly kidney disease or renal disease and your creatinine's going up, like you're not going to clear it as fast. So you might need the Narcan anyway to kind of counteract some of the consequences of overdosing. So these are just tools. These are just, advices that we're giving secondary to people that prescribe opioids for a population of patients.
It's a good point. It's a good
the-
point because it's readily available. It's free or not very expensive.
Yeah.
And it's a safety kit.
When we think of pain, and we all toss around that word, like we all know what it means, but what is pain and how is it broken down?
So pain is any noxious stimuli, whether it's emotional, physical, spiritual, that causes you distress. So it can be something like hitting your thumb with a hammer. It could be a child who's turned on you and their life has gone downhill and you blame yourself for the pain, that emotional pain you have. I think today we're probably going to focus more on the physical, but not ignoring the mental, psychological that goes along with that, because as we know, people with chronic pain, about 80% of them have concurrent depression. And there's a lot of physiologic reasons for this. There's also a lot of societal reasons for this. As people lose their identity, they lose their functionality. And all this compounds, especially with neurochemistry, where we use up certain substrates fighting pain, are the same substrates in our brain that focus and deal with depression. So it's a complex pattern. You need to recognize both the physical and it's not a psychological or psychosomatic, but more central nervous system, if we will, sometimes manifested in with depression or other aberrant type behaviors.
Yeah, it's so interesting. I remember when I was in senior in high school, I was going into senior year of high school. And when I grew up, I played basketball.
Mm-hmm.
And I remember the summer before my senior year of high school, I had played a few basketball games. And I think I had like 40 points, a couple of games, 35 points. Like I was playing really, really well. And I wasn't one of those guys that was like, oh, I'm going to the NBA. None of that stuff. I was 6 feet tall. I was good. Like I was going to play in college, whatever. My knee started hurting. My left knee started hurting in the beginning of senior year. I remember the football coach really wanted me to play football. So I was like, oh, I went to a couple practices. My knee started hurting there. I was like, okay, I'm not doing this. So I stopped that. And it continued to hurt throughout the year, but I never said anything. I pushed through it. There were times when it was really inflamed, never missed a game, always played well. But I got to this point to where something that I really, really enjoyed doing, like basketball was like my life. It was like, I woke up, I thought about it, I watched it, I played it, I
Dribbled all day long.
all day long,
Mhm.
all day long. And, some of my identity was through like just
Yes,
basketball.
absolutely.
Went to UC Davis to go play basketball. And my knee was just killing me. And I remember the day we were outside at the park and some of the other guys that were going to try out for the team or that had got recruited to play, we're all playing against each other. And I just remember the intensity that we were playing and the abuse that my knee was taking and the pain that I had from it. I was like, I can't do this anymore. I can't. It hurts too much. I just ignored it.
Right.
I just was like, I blocked it out and I was like, all right, my knee hurts. I got it. I can't let it affect me emotionally. But when I go back and I think about that time, I'm like, holy crap, this is something I did my whole life. Could not do anymore. And it was so painful, but I had the ability, I guess, mentally, whether you want to call it positive or negative, to just kind of take all that energy and put it into medicine, right? I remember my grandfather telling me, like,
Yeah.
you're going to go to medical school, you're going to do these things anyway. So I took all of my energy and I put it into that. But I just imagine these scenarios where you have individuals that have pain like that. They either don't put their energy elsewhere or they just let that pain, which goes from acute to chronic,
Yes, big difference.
affect them emotionally.
Yes.
And what you're seeing when they come into your office. I mean, my knees still hurt to this day, now
Yeah.
both of them. These are the types of patients I imagine that you're dealing with, which makes it very, very difficult to kind of diagnose or go back to, or how do you approach that?
If you look at pain, you can break it down a bunch of different ways: acute, chronic, somatic, neuropathic, visceral, psychic, a lot of different ways. So when you first see someone, somebody comes in, say they're a weekend warrior, they're doing what they do. CrossFit has been good for my business. Thank you. They get a new bulging disc in their low back. They've got some sciatic pain going down their leg. Prior to this, they're doing great. Evaluate them, see what the issue is, get imaging. You see that, okay, there's a disc bulge. It's not surgical for sure, but it's causing this sciatic, radiculitis in their leg. And so we maybe use some nerve medicines to calm it down, put them in therapy, do an epidural steroid injection. In a scenario like that, you typically, you see this patient, within a month or two, they're back at it, doing what they want to do. Those are great.
Yeah.
Then you have, say, the other end of the spectrum. Back surgery, 10 years ago, 3, 4 levels. Maybe it was done perfectly, maybe it was done not that perfectly, but it is what it is. You look at the imaging, there's no anything pushing on the nerve, there's no broken something or whatever, but you know that they have chronic pain. We have an actual diagnosis code for this, post-laminic knee syndrome. It's like you have pain after surgery.
Yeah.
Chronic pain is going to be different than that weekend warrior that we saw, a moment ago. And with the chronicity of pain, when pain is present for some time, the physiologic changes that occur in our body are dramatic. And after a while, they become more and more challenging to reverse. There's a fast nerve called the A delta fiber,
Yeah.
which immediately goes, hey, you stepped on something hard. And then there's these slower fibers called C fibers, right? And those are the ones that give you that kind of a long-term chronic, hey, this is bugging me. Sometimes people will be sitting there and they go, yeah, my back does kind of hurt, and those are the C fibers talking. They're like, hey, we're here. Hey, we're here. But the A delta, the fast ones, those are the ones that are going to say, boom, move your hand, get your hand off a hot plate, whatever it is. Immediate response when you have an injury, whatever it is the nerves say, hey, wake up. Second thing that happens is the tissue around there becomes inflamed. And these interleukins, these other cytokines that are released in an inflammatory, just like in the lungs or anywhere else, are going to sensitize that area, which is good. We want that. Pain is good for us. We don't want to walk on hot coals. We don't want to bump our head on a brick wall. So this inflammatory soup typically sticks around for a while. And after a normal period of healing goes away, whether use anti-inflammatories, hot, cold, whatever it is, but in normal healing stage. Chronic pain is defined usually somewhere around 3 to 6 months when the injury that occurred should have healed, but the pain persists.
Yeah.
Okay, well, why is that? Well, we gotta know. First thing that happens in a chronic pain state is, in addition to those 2 nerves we talk about, a beta fiber is kicking. And these are typically ones that don't transmit pain. So now, instead of having 2 groups, we've got 3 groups of nerves sending pain to the spinal cord. When it gets to the spinal cord, it sensitizes certain nerves in the spinal cord itself, which tend to augment or increase the signal. Normally, when we have a signal from a nerve going to the spine that goes to the brain, there's a 1-to-1-to-1 connection. Now we've got a 2 to 3 to the spine, and there's something called sprouting. So instead of going into just the normal parking spot of those in the spine, it connects with a level above and below that's called sprouting. So the amplification locally, the amplification in our spinal cord, and then there are certain parts in our brain that become amplified. And this chronic pain state now becomes hardwired. Instead of a little wire that goes from your phone to wherever, this becomes like a T1 cable line where it's like everything's coming through, and it's going to affect different parts of our brain. prefrontal cortex, the amygdala, the somatosensory cortex, all these now are activated. And a big reason for that is this certain type of receptor that we have in our central nervous system and peripherally. It's called NMDA. NMDA can be really good. When we learn something, if you're studying a book and you're reading about a new procedure, whatever it is, and you keep doing that, the NMDA is going to hard track that learning into your memory. But when you have NMDA hard tracking these pain pathways, not so good. So then it becomes a more complex approach to that patient. And how are you going to affect? Do you affect the local spot? Do you affect the spinal spot? Do you affect the brain spot? Or do you try to affect them all, which we typically do because you're going to get a little bit of this from here and a little bit of that from there. We've made great advances both pharmacologically and interventionally with a lot of the gizmos that we use for people, as well as recognizing the psychological stuff. And that incorporates cognitive behavioral therapy, how do I deal with your pain essentially. We ran what was called a functional restoration program for about 10 years, and then insurance stopped paying for it. And it's too bad because it was really helpful. And we'd have people come in with chronic pain. I mean, they were done. There was no more surgery. They were on opioids typically, not usually a lot, but they would go through the 6-week program where it was group talk, art therapy, which is kind of weird, but this art therapy really allowed them to express themselves. And it allowed this frustration, this fear, this pain. Anyway, this was more of a cognitive approach and a physical approach where we would have them do movements slowly and slowly. Had a lady came in, she was in a walker, and after a 6-week program, she continued aftercare for a while. She wound up walking a 10K race, which was amazing when here's this woman that we first met. And so these adjunctive things can be important and very, very useful. They're just usually not paid for. So we focus on what typically is paid for, medications, procedures, etc. And there's great value in those. I don't want to minimize those because the combination of those are both with the cognitive and the physical aspects are usually the best.
What you guys all heard throughout all of our conversation thus far is you said a lot of words like epidural, you said spine, you said nerves. I want you guys to understand, you guys all know that we have a brain, and the brain is the organ that's receiving all this information and processing all this information. The way that it does that is it basically sends out tentacles or nerves to different parts of the body, right? And when you look at the back, specifically when you look at the spine is a bunch of bones that are stacked on top of one another. Like, think of a stack of blocks. So you got a stack of blocks. If you leave that stack of blocks or that stack of brick, like we got behind us here, on top of each other, eventually the hardened part is going to erode. So what God or whoever designed us did is they put little mattresses between the different blocks. And we call these different levels of spine. We've got cervical, thoracic, lumbar, sacral spine. Within these blocks, within this bone, is our spinal cord. So it's the main pathway for nerves. And at every level of spine bone, at every level of cervical spine, thoracic spine, you have an exit point for nerves, right? So they're traveling just through holes. They're traveling through these holes. They go to innervate the arms. They go to innervate the diaphragm. C3, C4, C5 keeps the diaphragm alive, right? They go to innervate your butt, your thigh, your feet, whatever. So that way, when you hit yourself or when you're running, the information your brain receives from that area travels through your spinal cord up to your brain, and your brain might say, oh, I better run faster because my coach is screaming at me, right? So this is what your spinal cord and your nerves are all doing, and it's all cell communication. All the molecules are going to talk to one another at different receptors, which Dr. Paicius has already started to mention, NMDA, for example. So when you see and you understand that, you understand the anatomy. When he says something like bulging disc, what he's talking about is that little cushion in between the two levels of spine, in between the two bones there. That cushion has been squashed and it's displaced some of the tissue to compress on the nerve, which can cause pain. And when you compress on that nerve, not only do you have pain, or you have pain, but you also can have a nerve that doesn't work as well. It doesn't receive the signal as well. So you might become weak in certain areas. Now, this is what's taking place, right? And so when he's talking about imaging, getting MRIs or even CTs, He's looking to see the amount of destructions taking place at that level. He's looking to see the amount of inflammation that's taking place at that level. So on an MRI, you're basically looking at the amount of inflammation that's taking place because it looks at water. You can see the difference of inflammation because when you have more water, we know it's more inflamed, and that's what we can see on MRI. So understand that when we're saying these words, this is what we mean, but this is all easy stuff. It's just brick by brick. You've got a cord. We know what that cord does. We know and are learning more and more the molecules that are involved. So he's trying to understand, where is this pain coming from? And what he just said was, hey, listen, it might be coming from one place and I can see it, but because of the long acting of that innervation and those fibers feeling that pain, they're learning and creating new pathways of how to amplify that message, which they do with a certain receptor that he mentioned called the NMDA receptor, which is responsible for creating new connections and letting nerves be like, oh, that's what this is. That's what this is. And so it's almost like your spinal cord is learning that you have pain. And so you just keep having pain.
That's right. That's exactly right. It's a great description. When we look at the spine, people come in and I tell them it's a facet problem or a disc problem or a bone problem. And again, so your description is perfect. It's the vertebrae are stacked on top of each other. In between, you have a disc, which is kind of soft, kind of leathery on the outside, goopy on the inside. And where the bones meet in the back of the back, there's a little joint. It's called the facet joint, just like the facet of a diamond ring. And these are the areas that we normally see in run-of-the-mill pain stuff, where someone, as we age, things get degenerative, and it doesn't have to be that old. I have pro athletes who are young, and they have, probably more wear and tear from, as you described. So when we look at this, we look at imaging, we look at the examination, we see where the pain distributions are, but it's not dictated by the MRI. I had an older gentleman come in a few weeks ago. I had an MRI of his neck and I had an MRI of his low back, and I looked at his cervical spine, and I was like, how is this guy walking?
Yeah.
And his lumbar spine wasn't a lot better. And I go, well, how's your neck? And he goes, neck's fine. It's my back that hurts. I'm like, okay. The MRI, especially if we're going to do interventions, is helpful to find out what's going on, where it is, and hopefully it correlates. There's actually a guy, Brant Zawitsky, is a radiologist at who published in the New England Journal a number of years ago.
No, this guy,
That-
DZ.
Yeah, well, that's another story. So, but he did publish a good study where he looked at MRIs of, 100, 200 people had no spine pain, and 100 or 200 people that did have spine pain. And when you looked at it all across the board, the MRI didn't dictate what was going on, because you had people with nice looking spines that had a lot of pain. You had people with really, the warranty is expired. Those are helpful. Those are all tools. As a clinician, as you know as well as anyone, you need to put all these pieces together to figure out what's going on, and then what are your options. And of course, when we talk to patients, we tell them, this is what we believe is happening. And the options are do nothing, nerve medications, maybe low-dose painkillers or anti-inflammatories, procedures, etc. And we, build it and say, my best guess, experience would say that if we do this and this, you should do really well. And some people are like, great. Most people are, yes, okay. They come to me for my opinion, and fortunately, they usually follow that opinion. But some people say, I don't want any procedures. I'm afraid. My cousin got paralyzed from some pain. Like, whatever you want to do is fine. I'll work with you, whatever you need to do. And then again, whether it's going to be a medication, an injection, a rhizotomy where we burn nerves in certain areas, depends with you. We try to customize it for the patient.
What patient case has stuck with you throughout your career?
I'll tell you, early on in my career, one that kind of really motivated me. There's a thing called an intrathecal pump. And what it is we put a little tube in the spinal fluid. That tube is then connected to a reservoir, a pump, and that's placed under the skin. So everything is self-contained. We can put whatever medicine we want, and that'll affect the central nervous system. One of my first pumps that I implanted was for a 35-year-old woman who had MS, multiple sclerosis. Was in a wheelchair, couldn't walk.
So multiple sclerosis is an autoimmune disease that affects the nerves. And so you've got these fibers that are wrapped in stuff to make the nerves travel fast. And when the immune system actually attacks what's called the myelin sheath, these fibers, then the nerve signal doesn't travel as fast and people have all kinds of symptoms. But that's what multiple sclerosis actually is.
Right. So one of the treatments for MS was spasticity, which was her problem, muscles contracting involuntarily. is a drug called baclofen. Been around for a long time. So we did the pump. Everything went well. Sent her home. She came in for post-op a week or two later. Took out the suture. She was doing all right. Didn't really, not much going on. A couple weeks after that, I get a call from her mother. I'm in the hospital at that time. So I'm like, hey, what's up? He goes, will you see Julie? And I'm like, yeah, we can make it. No, I just want you to see her for a minute. I'm like, okay, I've got a break around 3. I'll just meet you in the hospital lobby. So I'm in there waiting for her. Julie walks in. She hasn't walked for 3.5 years. She walks in without a crutch, without a walker, without a cane. And she wasn't ready to play basketball. But she was walking on her own. And I was like, I immediately called my wife. We're both in tears. We're just so happy that this. And I thought, okay, I found my calm.
That is an absolute wonderful story that I hope I'll be able to relate to in the future with my niece. But
We'll get you, buddy.
now it's time for What's the Buzz, presented by BuzzRx. Every week, I answer a health-related question from one of our viewers. This week's question is, hey doc, how do drugs like gabapentin or pregabalin help with pain? This is a great question. When you look at gabapentin, what it actually does is very interesting. It binds to a voltage-gated calcium channel in the central nervous system. This leads to the inhibition of calcium influx into neurons, which reduces excitatory neurotransmitter release. This is going to dampen the overactive nerve signaling in neuropathic pain. Pregabalin binds that same voltage-gated channel, but it has a stronger affinity for that channel. Both of these products can be obtained if prescribed by the prescriber using the BuzzRx coupon. And if you have any questions, email us at healthexchangepodcast@gmail.com. Just remember to look up your medications on buzzrx.com or the BuzzRx app. Thanks for joining. One of the other things is there are patients that have chronic respiratory conditions, like chronic obstructive pulmonary disease, right? People who are suffering, they can't take deep breaths, they have a lot of attacks, exacerbations.
Third leading cause of mortality in the United States.
Correct. These patients can have pain. Have you ever seen any COPD patients in clinic?
So not as much as you think. I think data shows that COPD patients, 50% of them at least, have chronic pain.
Yeah.
But typically they're so focused on just breathing that the pain is like, I'll take it. Just get me at the next step so I can walk to the living room. And when we look at pain in COPD, it's in multiple areas. There can be inflammation in the lung itself, the lining of the lung, the pleura. There can be inflammation in their pleurisy. That's certainly one area. What's more common is the ribs, the intercostal muscles, the accessory muscles in their neck and their shoulders to help them breathe, to get those deep breaths. You often see them leaning forward to get this position where they can expand their lungs the most, and that causes chronic back pain. So when we look at this and we try to evaluate what's going on, you have to be delicate. You want to avoid opioids as much as you can because they're respiratory compromised.
Yeah.
You don't want them nodding out at night.
Not breathing, not taking big breaths.
They're not waking up.
Right.
Another part of COPD are headaches, typically either from low oxygen or too much CO2 when they're sleeping.
Right.
So these physiologic changes are best approached whatever we can do, whether it's CPAP, whether it's supplemental oxygen, those forth. We avoid injections into the ribs, into the intercostal, because if we get a pneumothorax where the needle goes too far and the difference between the nerve in your ribs and the location of the lung is about 1/4 to 1/2 inch.
Yeah.
One slip mistake, the lung can collapse, and then you've got a heap of problems.
Right.
So the interventional things into the thorax, into the cage itself, are minimized unless it's something specific, significant, or whatever, broken ribs, say. And a lot of these people, because they're on steroids, they often will get osteopenia, thin bones. They'll cough and cough, they'll break a rib. And in those cases, injecting under fluoroscopic guidance into the fracture can be beneficial.
So do you inject into the fracture, or do you inject, and this is honest.
Yeah.
Or do you inject, I know when we're doing procedures, when I'm sticking a needle in somebody's back, I want to go over the rib because the vein and artery and nerve run right under it.
So we want to go below the rib because we want the nerve.
You want the nerve.
We want the nerve. So we'll go proximal, closer to the spine, from the fracture to anesthetize the intercostal nerve,
Yeah.
as well as put some anti-inflammatory medication in there to decrease the swelling. The good thing about pain management now is regenerative medicine has really kicked in. Unfortunately, you have people espousing regenerative medicine, and it's from A to Z. And you'll have a chiropractor who will have a nurse practitioner come in and do some weird injection of something that's whatever. You don't know what it is. They charge a lot of money, and maybe the placebo will help you, but that's about it.
Right.
Other end of the spectrum, you've got $500 billion in companies that are developing specific stem cells that will affect certain areas. In a practical standpoint, we just finished a study with a Korean company where we took people, and if we look at the level of degeneration in a knee, there's a KL score. 0 is like perfect. 4 is bone on bone. And these were KL3, so they were pretty bad knees. And what we did is brought them in. I did liposuction on their abdomen. These are stem cells in there, and they're good. Adipose stem cells are really good. We sent them to Korea. They extracted the stem cells from the fat, multiplied it, sent the cells back. We injected in the knee. Home run. Average age of these people is 72. So it wasn't a bunch of spring chickens that we were just moving along.
And again, a lot of people, they say, "Oh, I'm just going to get stem cells. I'm just going to get stem cells." So what are stem cells?
Let's talk about the products.
Yeah.
Let's talk about it. If we're looking at a catalog of regenerative medicine, probably the simplest thing that's probably the most common, and has good data, especially for what you have. PRP, platelet-rich plasma.
Yeah.
The way that's done is we take out a bunch of blood from you. We put it in a centrifuge at certain speeds a couple times, get this fraction, which is rich in platelets, which tend to cause an inflammatory response. So we inject that into your tendon. It's not comfortable. So we localize it first, but afterwards it's still sore for a bit. And that causes a huge fibroblast formation to come in and repair that tendon. So in tendons and ligaments, we know PRP is great. Now, PRP is used for other things, maybe good, maybe not so good. The data it's not robust data. There's studies that show 30, 40 people. That's not really powered well to give you a real answer. That they'll use it for, back stuff or knees, the sets, whatever, and so like that. So PRP is the starter, and that's not that expensive. Anywhere between $800 and $1,500 to do that procedure. Insurance doesn't cover it.
Yeah.
They won't cover anything that's good for you.
No, they don't.
Okay, so then let's move on.
Yeah.
Okay, so the next product, something called exosomes.
Yeah.
So exosomes, so when you look at a stem cell, how does it work? Well, if you have a stem cell that can turn into other cells, that's one thing. But most mature stem cells, they don't do anything, but they release these little vesicles that come off their surface.
Yeah.
These little vesicles are called exosomes. They can contain anti-inflammatory, pro-growth, pro-blood vessel growth, etc. And exosomes are really good for, I believe, more systemic problems. You can talk about some of those things that we've treated with that neurologic, some weird pain states called CRPS, which have shown really great promise with that. So that's another product, exosomes. And I think those are better served for you have a systemic problem, usually intravenous. Another product, before we get to stem cells, is something called Wharton's jelly. Mm-hmm. Wharton's jelly is found in the umbilical cord. You look at the umbilical cord has a vein, 2 arteries, and all this tissue, all the substrate around that is Wharton's jelly. It has some pluripotential stem cells. It has a lot of anti-inflammatory and pro-growth, because you figure this is lunch line for the baby.
Yeah.
So it needs everything it can to grow and prosper. All right. So you're going to get a scoop of brown, a scoop of green. It's going to be good for it.
Yeah.
Wharton's jelly, from a economic standpoint, is relatively cheap. It's from donated placentas. So if the mom will have a baby, the lab picks up the placenta, they separate out to get this product. Okay, and last thing is stem cells. We have stem cells everywhere in our body.
Right.
As we age, the stem cells aren't as productive as they used to be, with the exception of the adipose cells, because they don't turn over that much. So their relative age is young. When we take stem cells out of your bone marrow, Bone marrow is churning all day long. It's making new cells. It's just what it does. It's a factory. It's going on. So we look at the age of those cells, something called telomere length, which is kind of a indicator of cell age. Shortened methylation, another indicator of cell age, is higher in these people as we age. Another option is allogenic. That means it comes from somewhere else. We get them off the shelf. Companies will get stem cells either from placenta, from the tissue. They'll grow it, or they'll not grow it, or they'll just harvest it. But autologous, getting it from yourself, is probably the best because you don't have to worry about rejection. You don't have to worry about some genetic variant that might goof you up, okay? I had a buddy of mine recently, one of the healthiest guys in the world, former NHL all-star player. His buddy was investing in a stem cell clinic down in South America. This guy's still kind of a minor celebrity. He's got a following and such. He brought him down there to get treatments. He got shot here, there, wherever, and stuff, IVs, all this kind of stuff.
Just
And
because.
for just social media stuff. And they wanted him to be like, somebody
face,
sort of famous. Related, not related, healthiest guy I know. Comes down with metastatic colon cancer. I have heard of other off cases of going overseas. Yeah. Getting stem cells. And when you look overseas, you're going to be really leery. I mean, because you don't know what's going on. You don't know if their production is accurate, if it's clean. They're good at marketing, and the prices are better than you would get in the United States. But I would be very leery and suspect of going overseas for stem cells because you just don't know what you're going to get. And was that related with my buddy? I don't know, but I have two other friends who are friends or acquaintances. I know people who had done the same thing and came down with some horrific. So I'm concerned about the genetic aspect of that. So using your own cells, I think, is great. The Korean company that we did and sent their cells off, we can do it now. We don't have to do a study. There's a company a lab that we partner with in Florida that will multiply your cells. So I'll do the liposuction, send them over there. They'll multiply your cells, and they'll multiply them as much as you need. And depending on what you need, we'll produce and provide, inject, whatever we do for it. Involved in another study right now from a company called Mesoblast, and we're in phase 3 study now. And this is for the disc, the intravertebral disc, and we're recruiting patients right now. And if you haven't had surgery, but you've got one or two bad discs, we will inject stem cells. And we did phase 1, and the people that we injected the live cells, home runs, completely great. So this is phase 3 to get FDA approval.
It's fascinating thinking about stem cells. Most people think that, oh yeah, just give me stem cells and everything's cool. It doesn't quite work like that, right? You have to set up the environment appropriately. So when you inject these things, it's not that all those stem cells live. Some of these stem cells die out. I was just telling you about this article that was published in Nature a couple of weeks back by the guy who developed
Yamanaka.
Yamanaka. And there were 4 patients that were completely paralyzed from a spinal cord injury, and 2 out of the 4 now can walk after using pluripotent stem cells and injecting it into that area of the spine where it was damaged. And, there's basically different classifications for how much you're walking and things like that, but I can't remember the exact number. I think it was like 4 out of 5. 5 is the greatest. 4 is great. But that's what's fascinating about stem cells. And it seems like in your field right now, in that regenerative medicine, spine, joint, pain field, it's extremely efficacious.
Oh, yeah. And again, knowing how much and knowing where. Let's look at this mesoblast that I was telling you about.
Okay.
When they first were doing the preliminary trials, they were using a little bit, a medium, and a lot of stem cells. A little bit didn't, it's like Goldilocks, it's like this too hot, this too cold. Yeah. So the little bit sort of helped, didn't do much, 2.5 million cells, 5 million cells into the disc and to work really well. And 10 million cells caused this incredible inflammatory response where these people were laid up for months. And it eventually resolved and they were fine and actually did well at the end. So knowing how much, where, and what, because when we inject the knee, that's probably the most common thing I see. I see people come in with arthritic knees that put stem cells in, either from their fat or off-the-shelf stem cells. More is better, and the joint's more better, because when you use stem cells that are off the shelf, say, they don't live very long, but what they have is they have something called a paracrine effect. So these stem cells get into the affected area. They're like little detectives. They go inflammation, degeneration, poor blood growth. So they're going to send out signals, these exosomes, these microvesicles that go out in the system, and they're going to recruit. It's like the clarion call for your stem cells. You're going to come in, and your own stem cells are going to gather and complete the repair, because the original cells that we put in there probably last a week at most.
Yeah.
Except for what seems to be different are these adipose tissues, these adipose-derived stem cells. They seem to stick around a little bit longer, and they tend to do more and actually can morph into chondrocytes, which is what the cartilage is made of.
Oh, that's interesting.
Yeah, so I mean, that's like a whole new, and then there's one other side note, as long as we're doing this, there's another stem cell subset called Muse, M-U-S-E. What they found is that these are like SEAL Team 6. These are the stem cells that can really do the work. They found them by stressing a group of stem cells, and the ones that survived were the ones that would last the longest, that would do the most, and be the most pluripotent when you used them. Isolating them, segregating is expensive. But if you use a big batch of stem cells, you're going to get new cells in there with it. So there's definitely an art to this. And we know that from these studies that I've been involved in, incredible benefit. And it's really, when we look at pain in general, we look at degenerative of the spine, we look at neurodegenerative problems in people, we've got just a super exciting field ahead of us.
Yeah. And it seems, one of the things that you've been able to do, which again, I found fascinating a few years back when I originally met you, is you've been able to transition to completely private practice,
Mm-hmm.
but remain academically involved because of the research that you invite into your facility, which
Right.
I think is amazing. And it's rare for physicians like us to be
Mhm.
able to do that.
Mhm.
But it's so important because it just allows you that academic, artistic mindset, and you have patients that can really benefit
Right.
from these clinical trials.
Right. So we're doing stuff that you can't get anywhere else.
Right.
And that's the beauty. For me, I've always felt like I should have been in academics, but with doing research, and I've, since I was kind of early on in pain, I've been well connected with everybody in the business. Having this structure, this framework allows me. And so I'm getting a little of both, I'm getting that academic thing. I'm getting that reward of looking at new and exciting things. I love this stuff. I'm always, we tried doing some things with people with ALS, which is a horrible disease.
Yeah.
We tried some different things that were sort of helpful, but not enough to really pursue.
So when you see patients and they're coming into you with pain, when do you decide if you're going to do conservative management versus interventional management? Are you like, okay, wait, let's try these pills first? Or are you like, you know what? Hearing your problem, understanding what you're going through, you probably got to be invasive now.
It's not common, but I see a lot of it because of what I do. There's a disease called complex regional pain syndrome. CRPS used to be called RSD, reflex sympathetic dystrophy. And what happens is someone will have a minor injury or minor surgery, wrist, foot, typically. Everything goes well, it's done correctly, but that chronicity kicks in quickly. And so say someone had a carpal tunnel, simple outpatient 10-minute procedure. Boom, boom, nothing, great. They come back for their first post-op, hand's still pretty swollen. Okay, well, maybe you're taking a bit to heal. 2 weeks later, it's just as bad or worse. Uh-oh, we think this neurologic inflammatory problem, CRPS, is kicked in. So when someone comes into me with CRPS, yes, there's medications that can help, but they're going to need interventions. And I tell them, I go, we can start with meds. You need a sympathetic nerve block to start off. That's going to be the best thing. And some people are like, well, I just want to start with meds. Fine, whatever you want to do. I'm going to give you all the options. You pick what you want. So sometimes when people come in, and I know that's what they are. I've had people come in, back surgeries, they've got persistent radicular symptoms, sciatic pain. I know a spinal cord stimulator is going to be the best thing for them. And because when you bring up a spinal cord stimulator, we're going to implant 2 electrodes in your spinal column. We're going to have a battery that's also under your skin that maybe you recharge every few weeks. And they're like, what? So you can't, you just can't, I mean, you're not going to Frankenstein them right away. You need to present things in a timely fashion. So a simple injection, that can be a little bit more, I wouldn't say aggressive, but more convincing. but then I'll bring up spinal cord stimulation, which is a great device because it's been around for decades. I do a lot of them. I've done thousands of them.
Yeah.
And published most of my publications are on spinal cord stimulation. Yeah, this art with the patient of some people come in and say, I don't care what you do it now. Had a real estate agent, real type A guy came in a couple months ago with this problem, and we were very aggressive on it. He's doing great right now. And so sometimes when someone has a new like CRPS, the sooner you intervene, the better it is because that chronicity, there's hard tracks, that T1 pain wire that's going to go from your periphery to your brain is going to start establishing, and you want to shut that off right away. So sometimes it's important to be aggressive in your treatment. And sometimes you can wait. It's, you want to try PT first? Great, just do PT.
One of the things that you offer is you offer ketamine, right?
Mhm.
For not exactly pain management, right? But for treatment of depression, because we all know depression affects millions of Americans. People are lost their interest in life, anhedonia, we call it. And
Mhm.
these people are depressed and they don't respond. It's like 50 or 60% of people don't respond to the first line therapies, the SSRI, things like that. And so there's been a lot of research into ketamine. And I know that you offer it to your patients. Tell me about ketamine. Tell me about the receptors involved. Tell me how you use it in depression.
So ketamine's been around since the 50s, came up as an anesthetic, commonly used in veterinary medicine because you can give an intramuscular injection and doesn't cause respiratory depression.
Right.
Other anesthetics, inhalation anesthetics, propofol, opioids, they can all decrease respiratory drive. So it's common in veterinary, but we've used it in anesthesia since day one. So it's a good adjunct medicine, especially someone who's older and frail and you're concerned about their pulmonary status. You may use more ketamine than you would otherwise in someone to minimize the deleterious effects of other general anesthetics. That being said, about 15, 20 years ago, they noticed that, number one, high doses of ketamine from pain patients was helpful. Low doses in depressed people were very useful. And long circuitous story about both of those, but needless to say, ketamine is a central acting medication. Essentially works on glutamate at guess what receptor?
An NDA receptor.
That sucker. He's always coming back into the picture.
Yeah.
So what happens typically is when you administer ketamine, first thing happens, all the glutamate's emptied out. And what we see in depression, also in pain, but in depression particularly, you have these hard tracks that are wired with depression. And what the ketamine does is frees up these bonds between this cortex to limbic. And the limbic is the first original part of our brain.
Emotional.
Yes, it's where emotions are stepped. It's how we express, it's how we deal with pain or depression and or other difficult, stressful situations in our life. So we know that these limbic attachments are very strong in depression. The ketamine, via the essentially inhibition of glutamate, will allow some of these hard tracks to start not being so hard tracked. So when we look at most of the evidence with ketamine and depression, comes out of Yale. They have been the pioneers in this. And their standard is 6 sessions, 2 a week or 3 weeks. And that tends to give it more longevity. When people come in and they say, well, I'm not sure, but I want to try it, we mandate 2 sessions because one is usually not enough. And they almost always respond. I would say 80% of the people respond in a very, very positive way. But the durability is not there. So we encourage them to do more. Typically what occurs is they'll meet with our psychologist just to explain what's going on and how you'll feel and all this. And she's undergone ketamine for depression herself numerous times. So she gets it. She understands. So she's not going to take you away from your own therapist. She's going to be a coach essentially for this treatment. They'll come in, they'll meet with her. Then we set up a couple sessions where we have a care nurse monitoring the patient, infuse ketamine for about an hour, usually at a milligram per kilogram basis, which was a little higher than the Yale stuff, but when you dissect the subparts of Yale studies or any studies in ketamine, more is better. Mm-hmm. So it's still reasonable. You're there for an hour, you're kind of goofed up for the rest of the day because ketamine is a dissociative anesthetic. It kind of takes you out of your body. You may hallucinate, you may not. So, but those are good things. We want that to occur. We avoid any of the benzodiazepines because that's inhibit exactly what we're trying to do. So if someone's getting a little stressed, we may turn down the volume of the ketamine at the time it's being administered. We really want to avoid any benzodiazepines. Benzos, Valium, Xanax, Klonopin, Ativan, all these are long-term extremely negative for your brain.
Yeah.
Not only for depression, but for Alzheimer's and other forms. So we don't want that to occur, not in the short term, not in the long term.
Yeah.
If I travel, I might take some Xanax with me so I can sleep and when I'm somewhere else. But periodic use of that's not a problem, but the chronic use is definitely fraught with a lot of problems.
Yeah, so, the way I imagine ketamine working, because I always like to come up with analogies
Mhm.
to help
You're good at that.
this, right? And one of the things I was thinking of is I was like, if you think about the nervous system and you think about pathways that have been created, just like in chronic pain, where you get this pathway and your brain knows that there's going to be pain and hardens that pathway. Same thing can happen with depression. So you have these pathways in your brain that are created, right? And you've got the depression pathway and the nerves are firing and
Mm-hmm.
going, whatever.
Mm-hmm.
I think of ketamine as if you have a paved road that's leading to a cliff and the car is driving and you can go off the cliff. That doesn't sound very fun. But just imagine when you get ketamine, now you've got construction coming in. They've broken up that road and they're trying to take you somewhere else. Maybe
That's
they're
exactly
taking you
right.
towards the beach
That's
instead
right.
of towards the cliff, right?
Uh-huh.
And so you're able to almost, redesign how those pathways are hardening.
You're breaking down the Autobahn into side streets.
Yeah.
Mm-hmm.
And you're allowing yourself to go to a happier place, which I think, sometimes it can be an issue in depression. And I've seen, depending on what study you're reading, some of these rates of efficacy are like 80%, 75%, like, which is really high in terms of these patients being, not having depression any longer. Yes, we're going to need repeat therapy.
You might, yeah, it's not unusual, but my take is we all get depressed, okay? Something bad happens. Oh, we lost some money. A kid got sick. Whatever it is, we all get depressed. But those are usually situational, time-based things that resolve. Okay, death of a spouse, whatever. Those are normal things. But if someone is suffering and they get to the point where this is now chronic, truly, I would advocate just doing the ketamine before you get on an SSRI or a SNRI. Why not? Because why go through all this and be subjected to this lifelong commitment to the pharmaceutical company where you can cut it in the bud? So even though the indication is for medication refractory depression, I've seen it and we've done it with people who have relatively new onset.
Yeah.
We get a referral from the psychologist who's like, this person, doesn't want to take the antidepressant medication. Would you consider? I'm like, absolutely. And to be honest, those people are done better than anyone because you get it early and they're not subjected to months or years of, but not to say that, antidepressants are bad because they really help a lot of people. So I don't want to just minimize that and say they're not good. But if it was my family and looked like it was real depression that was kicking in, it was going to be a chronic thing, I would administer ketamine first.
One of the problems with medicine, and it sounds like you're going to agree, is that the chronology with which medications have been created have also led to standards of care developing in the same manner. So in other words, if this medicine was created first, it doesn't matter if there's another medicine that's way more efficacious. We're still going to use this medicine first because that becomes the standard of care because of the chronology in which it has developed. But when you look at the way medicine has changed, in other words, we now understand the pathways that are involved
Mm-hmm.
in the pathophysiologies, and we can actually go in there and completely manipulate that pathway now. For some reason, medicine, FDA, whatever, has not adopted.
We're stuck in this algorithm of treatment.
Yeah.
Good example. Good friend of mine. One of my best buddies. He's got high blood pressure. Left it untreated. I get him. I say, look, go to your doctor, and they're going to want to start you on these older meds. But you can't get a generic, ACE or ARB, angiotensin converting enzyme inhibitor or a angiotensin receptor blocker, which are less side effects, just or more
Better.
effective
Yeah.
without side effects. So I give him a list of these drugs. He goes there. He comes back on a diuretic.
Yeah.
He goes, I'm peeing all the time. Like, that's what a diuretic does. And this is just for a common thing like blood pressure. And then we can get even further along, with the cholesterol medications and everything. It's like, why not just go for the good stuff?
And it's the same thing in asthma, and it drives me up a wall. I mean, asthma is a systemic inflammation. Right?
Yes.
Some of these people genetically have higher eosinophil levels, higher IgE.
Mm-hmm.
And I have all these physicians that are giving these local therapies, and these patients are continuing to exacerbate, continuing to have problems, but they're fine most of the time.
Mm-hmm.
No, that's not the way that we do things. We understand
Yeah.
immunologically what's
Right.
going on. Let's use the product
interleukin
that
problems and
Yes, that
uh-huh.
inhibits that inflammatory mediator. And so, like with biologic, and it's just one of these things where medicine's got to get over itself. Like for me, it's just kind of like, listen, like we know pathways. Let's treat pathways and immunological cellular communication
Yes.
ish pathways
Right.
instead of treating specific diseases. Why do I have to wait? When I
Why
know what the
wouldn't you
pathway is?
use something that's going to inhibit the inflammatory components versus a steroid?
Yeah.
I mean, okay, so you're going to get steroids, and you're going to get steroids, and you get brittle bones, and you're going to get fractures, and then you're going to have compression fractures in your spine.
Yes.
Whereas if you cut to the chase and use something that was actually addressing the specific biochemical reaction that was going on, you'd be ahead of the game.
Yeah, and it's just one of the issues. It's like,
You have to
oh,
fail
we need-
this. You have
right,
to fail that.
we need a
You have to fail
comprehensive
this.
analysis. And I'm like,
Right.
I keep giving this patient this. They're gonna keep being in my
The
office.
comorbidities are going to escalate, and that's the thing that they don't look at.
No.
They look at just the in your case, the pulmonary function.
Right.
When you look at the comorbidities of the pain,
Right.
of the potential osteopenia that will occur with steroid usage,
Right.
there's a lot of problems. Same thing with cholesterol medicine.
Same thing.
You've
Yeah.
got a drug like Repatha, which is a PCSK9 inhibitor,
Yeah.
and it's going to shut down your LDL better than any other drug. But no, you need to start with a statin. When you fail that statin, you have to try another statin. When you fail that, then you go to Zetia or whatever you're going to do. And to get authorization for a PCSK9 inhibitor is Herculean.
Yeah, it's all based on chronology. Just because these drugs were created first and this one's pill, and it makes zero sense when you can look at people genetically, immunologically, and understand pathophysiologically exactly what's going on. This is how I want to manipulate the pathway. This is going to be the most efficacious. And it's not
Yes.
like, oh, I want this person in my office all the time. No, it's like, I want to do the procedure that I know is going to nip this in the bud.
Mm-hmm.
And I'm not going to see the patient in my office all the time. I do not care. Like, I want the patient to be better.
Imagine you went to a spine surgeon and he says, well, an artificial disc in your neck would be the best, but we're going to have to do a laminectomy first, and then we're going to have to do a fusion, and then you can't get the disc replacement.
Right.
Okay, sign me up. So
Right.
fortunately, that doesn't occur in spine because we know that the outcomes are measured and that this is going to be a little more expensive. It's going to be long-term, more beneficial.
And I know that you have a positive experience from your life that you want to share right now. Again, at the end of our episode, we always talk about a positive pulse. Is there a positive pulse that you want to talk about right now?
I had a couple come in, older gay couple. The one gentleman was suffering from AIDS, and he also had a Kaposi sarcoma, big tumor growing in the skin, invading all his pharynx and neck, an incredible amount of pain. So we started with pain medications, and they were effective, but they made him so sedate that he really couldn't function. So again, getting back to that intrathecal pump, which I don't do a lot of. These stories just happen to be these two that were remarkable. This guy's on really high dose of morphine just to get by, but he's just miserable in his life, not great, and couldn't do anything. He was sad and most of the time, didn't do anything. Joy was gone completely. So normally when we put in an intrathecal catheter, a little tube to deliver medicine in the spine, we usually go about the mid-thoracic spine because it's safer there. We avoid going into the neck because there's not that much room, and the potential of a granuloma, which can form and cause paralysis. So we want that. But I knew that this guy had not a lot of time left. So he did. I implanted it and I used something called sufentanil, which is a very potent narcotic, but just a tiny amount. And because of its lipophilicity, it stuck right there in the spinal cord where it needed and didn't travel and make him sedated or do anything else. A week after, no more oral pills, right bushy tail, had zero pain, and he lived for another 2 years till the cancer consumed him. But in those 2 years, he was pain-free and was able to enjoy him and his partner's life the rest of the way through. And that was, again, one of those tear-jerking moments that I shared with my wife. And
That's a great moment. I mean, that's, to be able to give somebody their life back, which is literally what you did.
yeah,
You allowed him to have life, his last 2 years of walking physically in this stage of life. And I think that is, that's amazing, right? And I think that's absolutely amazing. You allowed somebody to live before they die.
yeah,
Instead of,
that's exactly well said.
when we look at this, you guys, just because you have pain doesn't mean that you have to deal with it. Again, as somebody who has gone through pain, I'm sitting here thinking about the knee pain that I have right now, and I'm like, there are solutions. There are so many different types of solutions, especially with regenerative medicine and the different procedures and the different therapeutics that Dr. Paicius can use to help you. If you're having pain and you have questions, here's a solution. Someone who's listening to you can understand what you're saying and can offer something for you that may work. And I think if there's anything we want to do for you, it's to offer you some hope and some advice that's going to help you. Anything else you want to say, Dr. Paicius?
No, you summed it up really well.
Thanks for coming.
Awesome.
Thanks for being here. It's
Great
been
seeing
great.
you, man.
Gotta do
Awesome.
lunch again soon.
Yes, sir.
It's been
Ah,
a
you
couple
bet.
years. Yeah.
We'll fix up your knee. We'll go play some hoop.
Where? Oh, for sure. Where can people find you?
I'm in Newport Beach, Fashion Island, and you can look up my name or Southern California Spine and Sport Medical Associates.
Thanks for watching the Health Exchange. Find Dr. Paicius if you're having pain or if you want to go to lunch or if you want to play hoop. We're on Instagram at the Health Exchange Podcast. Get us wherever you get your podcasts every Thursday morning at 6 a.m. Pacific, 9 a.m. Eastern. It's been great to talk to you guys again. We'll see you next time.